Um, and obviously, this is a very informal sort of open discussion. I want you guys to ask questions, be involved. I'm going to call on you, and I want you to try to just guess. If you know, great. If you don't know, I still want you to guess just to show that we're involved in thinking. So let's start with, basically coronary anatomy. So in terms of coronary anatomy, I'm talking about essentially the coronary artery heart vessels, right? And so why do we worry about the heart vessels? What problems do people run into with their heart vessels? Clots. When you say clot, what exactly do you mean? Because that can be sort of construed in different ways.
Like maybe from the arrhythmia, like AFib, when it kind of just stays stagnant and then clots in the vessel.
Yeah. So when you use the word clot, that means actually like a thrombus formation, and a thrombus formation is a specific thing that has to do with clotting factors and platelets and collection there. And so you can have a clot formed in your left atrial appendage, for example, and that would be, like you mentioned, an AFib, and that's different than a clot forming within a vessel like a heart artery. And so, in general, why do we worry about heart vessels? And probably a broader term would be, stenoses or occlusions or heart vessel blockages, to the layperson. Why do we worry about those?
Because then like the blood doesn't flow to the organ where it needs to go.
Yeah, what do we call that? Ischemia, right. And so, and if you're trying to tell it to a layperson, we're talking about heart attacks, right? So that's the #1 cause of death in Americans, and so that's why we have to be on the lookout for it. So if we're worried about the #1 cause of death in Americans, if we're worried about trying to reduce heart attacks, then we want to know what causes them, where they are caused, and then what we can do to take care of them or treat them, right? And so that's why it's important to learn what we're dealing with and the anatomy of those. And so you guys are taking care of some patients on the floor who've had heart attacks. Have they had either something done in terms of revascularization or treatment of heart vessel blockages? So start throwing out some names there of heart vessels, individual heart vessels that have had issues.
The left coronary artery?
So,
or the left anterior descending?
Okay, so right. So there's no real left coronary artery. There's the left anterior descending. Some other ones?
Circumflex.
The circumflex. What other ones have you heard?
The
right coronary artery. What else? So so to an extent, all of these can be names of things, and so do you guys ever look at films or see, like you say, okay, my patient had a right coronary artery stent. Do you go and look up in a book and see like where the right coronary artery is, or whatnot?
Sometimes, if I have time.
Yeah. Okay. So, and the reason why it would be useful is that you get an idea, because not all of these arteries are the same. Not all of them have the same sort of importance. Not all of them have the same sort of consequences when there are problems with them. And what we do to them depends on a lot of those different things. And so it's useful to know the different things about the different arteries and what the differences are amongst them from a physician as well as from a nursing standpoint. Okay? And so let's talk about some of the different things. I want you guys to sort of imagine your heart in your chest, and your heart in your chest essentially sits, essentially your heart is roughly the size of maybe your fist with your hand on top of it, roughly, and it's in your chest, and it's not right in the middle. It's a little bit to the left and actually more like pointed to the left. And so if you can imagine, I think it's sort of schematically, when I was in fellowship, one of my attendings, Al Reisner, kind of came up with this very simple concept, which I think translates well, is imagine two sort of ice cream cones, right? The actual, just the cone part. If you can imagine two ice cream cones next to each other, they come to a point, right? And if you can imagine two scoops of ice cream on top, right? So I'll have like a ball here, and then two cones. That's essentially the four chambers of your heart. So I have a left ventricle, a right ventricle, and then two scoops here. And what are those?
The atrium.
The atria, right? And so if they're sitting in my chest, they're not in the middle, and the apex, this is the point of the heart, it's not straight out, it's more pointed to the left and down, okay? And my atria are up top here. And then also, these ventricles are not identical either, right? One's the right, one's the left. And if I were to take these, and so there's no ice cream scoops here, there's no atria here. So if I cut away the atria and I were to look at it like this, and this would be the left ventricle, and this would be the right because it came from this way. And if this were the left and this were the right, what do we call this wall in between? The septum, the interventricular septum. If I had a wall in between the atria, I'd call that the intraatrial septum, right? And so imagine the right ventricle and left ventricle. If you were to look at it, where does the left ventricle send blood flow? To the whole body, basically, right? Where does the right ventricle send blood flow? To the lungs, right? And so if you could picture these two different muscles, essentially, which one's going to be thicker and bigger and stronger? The left. So when you picture it, it's going to be thick. It's going to be, imagine like, you know, a super chocolate dipped waffle cone, and then this was like some thin sugar cone kind of thing. And almost this cone actually, when you look at it, really, it almost kind of is a little floppy and bends around this big muscular cone. And so it almost takes shape around it. Because it'll really, all it has to do is send blood flow to the nearby lungs. This one has to send blood flow head to toe. And so now that we understand kind of the ventricles and where they are and what they have to do, we can understand that for these guys to work, we need to supply them with blood flow. So then we can understand, okay, now that I know where these things are, where my two atria are, I can kind of get a better sense of the anatomy so I can know where the blood flow goes. So just like the whole body needs blood flow with oxygenated blood to survive, the heart itself needs that. So how do you think that happens? How does the heart get its own blood flow? Yeah, so let's say you're an erythrocyte, you know, a red blood cell, you're in the left ventricle, you're oxygenated because you just came from the lungs, and you're going out, and let's say you're a red blood cell that needs to feed the heart itself. Where does it go? Tell me the path of this red blood cell. It starts in the left ventricle. The left ventricle is squeezing, and then where does this red blood cell go next?
It goes through the valve.
Goes through the aortic valve, and then from there, where does it go?
The coronary.
Yeah, so it takes like a sharp U-turn, a hairpin turn, and goes down one of the coronaries. And so how many coronary ostia are there?
Is it 3?
What's that?
Is it 3?
So it's 2.
Oh.
Mostly it's 2. In some, you know, variants, people who have anomalies, they might have 3. But essentially you have 2. One is the left coronary artery, or we call it the left main coronary artery, and then one is the right coronary artery. So this is sort of, I should draw it because that'll be easier to see. But in essence, if I have my left ventricle here, right, a big, thick left ventricle, this is usually around 1 centimeter normally, and if I have a little red blood cell here, and I go out this aortic valve, that opens and closes, and this red blood cell goes out this aortic valve. It literally takes a hairpin turn and goes into a coronary artery ostium that goes and feeds itself. And then there's another one on the other side over there, the right coronary artery ostium. And so this is something that's important to know, is that it's not as if the heart muscle wall absorbs blood flow from within it, right? It's not like blood just sort of, you know, goes in its way and feeds the heart muscle wall that way. It actually, a blood cell has to go out through this. Here's the aortic valve opening, closing, and then we have this coronary, we call it coronary sinus here. And in this coronary sinus is a ostium, and then here's the artery that supplies blood flow, okay? So this red blood cell will go out here and then go down this way and supply blood flow to the heart itself. So that's important to know because we have to understand that this is the lifeblood, the irrigation system of the heart itself, and then there's another one in the back over there. So now back to our ice cream cones here. So now I've got two ice cream cones, right? One is this thick left ventricle, and I've got my, and I'm going to talk more schematically here, left atrium, right atrium. I can picture that? And so what happens is I have to supply the septum, and if this is the left ventricle here, this is where the bulk of the blood flow needs to go because that's where the bulk of the work is being done. So I want to supply the septum here, and I need to supply this whole cone this way, this way, and this way, right? So if I go back to my cone here, and this is for all intents and purposes, let's just focus in on the left ventricular cone, knowing that the right ventricle is over here. So I have this septum that needs to get supplied. I have this anterior wall, and if it's sitting in my chest, and this anterior wall that needs to get supplied, septum, anterior wall. This is the lateral wall, and this is the inferior wall. Okay? So we know from our basic coronary anatomy that I need to supply these areas. So you had mentioned an artery. What did you say?
The left anterior descending.
So you can imagine then it's the left anterior descending, so that means it comes off the left coronary artery. So I mentioned that there were two holes from the aorta, so it's going to come off the left one. It comes off that left one, and that left main coronary artery branches into two vessels. One is the LAD, the left anterior descending. One is the circumflex. The LAD is coming off the left coronary artery, and it goes anteriorly, so towards the front, and it goes down. So we know that it's left anterior descending, and it's going down as in, because my heart is pointed down. It goes down. So the left anterior descending actually goes in this groove between the two ventricles called the ventricular groove, and it'll supply blood flow to the septum itself, and those vessels are called the septal perforators or septal vessels, and then it also supplies the vessels that go this way. They go diagonally, and those are called diagonal vessels. So you may have heard when you're taking care of patients that they might have had a stent to their LAD and a balloon to a diagonal. That would be what and that's the vessel that's going on there, okay? So what do you think? If I have an LAD and it gives off branches, what's bigger, an LAD or a diagonal? LAD. So picture an oak tree, right? It's got big branches, and then it goes out to smaller and smaller and smaller branches. And so the LAD comes off the left main, and it supplies the septum, and then this sort of wall here anteriorly. So if you have an anterior infarct, you're worried about a blockage in the LAD. The bigger the infarct, the closer to the origin of the LAD we're talking about. Make sense? So if I say, and this LAD, like I said, it's a left anterior descending, and it goes all the way down, and it goes all the way to the apex. And so the tip of the heart, the bottom of this ice cream cone, usually is covered by the LAD. Okay? Now, what did I say this area, this wall is called? The lateral wall. So the lateral wall, what happens is that the left main coronary artery branches. It branches to the anterior, and it also branches to the circumflex. And so that's what happens. You'll have the left main coronary artery, and it'll branch into an LAD, and it'll branch to a circumflex. And this LAD supplies these septal perforators, but then it also supplies these diagonal branches that cover the front part of that cone. Meanwhile, the left main coronary artery, circumflex, what does circum mean in Latin? Around. And so that's the thing. Imagine it goes in that round part of the connection between the cone and the scoop. It's going to go in that atrioventricular groove, and it goes around and goes around that lip. And then it starts to spread the branches this way. So now imagine, now I'm able to cover that lateral wall of that cone. And those branches are called what? So this is the circumflex. What do we abbreviate the circumflex? In the doctor's notes, when you see them, we put a PCI to the, CX or LCX, left circumflex or circumflex. And this is the LAD. And these are the diags, D1, D2, D3, and these are the septums, S1, S2, okay? And these circumflex, I'll write it out, circumflex remember the M in circumflex, and these are OM, obtuse marginals. OM1, OM2, and so that's why you remember these are the obtuse marginals, so they go that way. And a margin is on the side or the edge, and so that's what it is, on the edge of the heart. So that's how you know the marginals are supplying the blood flow. So going back to our cone, so now I got this picture where I've got this the left main coronary artery, and then it branches, and the LAD goes on this way, supplies diagonals this way, right? And then I've got this circumflex that comes off over here and supplies marginals this way. So now I'm covering a large part of this cone. I've got my septal wall. So if you can imagine, if I had some paint, I could paint this area getting covered with the septums. I could paint this area getting covered with the diagonals, and paint this area getting covered. So what's left? What's that? Yeah, the underside. We would call this the underside of the heart, and that's the inferior wall. And so what blood vessel supplies the inferior wall? Yes, so the posterior descending does, but the posterior descending is a branch of what vessel? I'm going to draw it over here just so that it's away from that. So this is the other ostium. The right coronary artery looks like this. So if you look at a CAT film and you see just one vessel come and looking like this sort of C shape, then this basically is the right coronary artery. It gives off a marginal branch, and then it comes down and it gives off the posterior descending artery as well as a posterior lateral branch. And so this is like the analog to the septum. So in essence, going back to our double ice cream cone model, right? So we're picturing this, two scoops here. So your LAD is going down here and supplying septal branches. Those septal branches, I was a little wrong, they don't supply the whole septum. They only supply about the top 2/3 of the septum. They can't get all the way far down to get the inferior 1/3 of the septum down here, okay? And I've got, just to recap, my diagonals, my marginals. And you remember the circumflex artery curves around and circumflex goes around here. The right coronary artery is almost like your mirror image of your circumflex. It's going to go in this groove here and come around this way and come around underneath and supply an underside version of the LAD. Okay? So instead of having the LAD, now I have a posterior descending artery. So instead of anterior descending, I have a posterior descending artery, and it supplies septal perforators going up. And that's what covers the bottom 1/3 of the septum. Does that make sense? And so it's very symmetrical. I got an artery that wraps around this way, this sort of atrioventricular groove, or in between this scoop and this cone, I have a one that curves around this way. And so I'm making this cross here. I'm covering this area in the front, this area in the back, and then I've got a vessel that wraps around this way and a vessel that wraps around this way. And actually, when that vessel comes around here, it branches into the posterior descending and posterior lateral so that it can help cover this area. And this area right in the middle there, in the back, is called the crux, which is the Latin word for cross. So now you kind of get an idea of the different vessels. You have your right coronary artery, and so when you think of right coronary artery, you have to basically be thinking of the underside of the heart, or inferior wall of the heart. When I talk about LAD, or left anterior descending, I have to be thinking about the anterior wall. And when I talk about a circumflex, I need to be thinking about the lateral wall, okay? And that's what happens when you're looking on your EKG. And so if you're looking on your EKG, so you got your patient, you know, he comes in with chest pain, his troponins 0.1, and, you know, we're thinking, okay, we're probably going to go do a stress, but suddenly in the middle of the day before a stress test, he has severe chest pain. Of course, you get a 12-lead EKG, and you see tombstones in the anterior wall. You're thinking you're worried about a what? Yeah, anterior MI. You're worried about an LAD being freshly occluded. And so if you're seeing anterior all across the precordium, V1 through V6, you might be thinking more a very proximal version, right? But if you're seeing it more just L4, L5, L6, maybe a little bit more distal, okay? And so you can kind of localize things that way from an ST elevation standpoint. If I see ST elevation, the 3 millimeter tombstones, and leads 2, 3, and F on my EKG, when you get a 12 lead EKG. What are you worried about then?
Well, so that,
But I'm sorry, what vessel are you worried about? If you see ST elevation leads 2, 3, and F. So those are your inferior leads. So 2, 3, and F on the 12 lead EKG, those are your inferior leads, and so now you're worried about an RCA lesion. So this helps you in another way. I mean, yes, I understand you're probably not too worried about which vessel it is. You know, it's like I need to call and get the guy to the cath lab right away, right? Maybe a more relevant situation would be somebody who came in stable and had an RCA stent, right? And the RCA stent just got put in, and they come back to the floor and they come in with and they start saying about chest pain after their stent. And this is a guy who really shouldn't be having a ton of chest pain, but then is having severe crushing chest pain, and you get your 12 lead EKG. If you see tombstones in that same area as the RCA, you're worried about what? That's if fresh, acute, we call it acute stent thrombosis. And so sometimes, and that happens, that those stents close off right away. And even more commonly with the drug-eluting stents, those stents can close off right away. So that is a very important thing for you to know, the differences in different locations. If you see, you know, you get your 12 lead EKG and you see ST elevation and then in the reading says acute inferior MI, and you, okay, well, where did my patient have a stent? If he had a stent in his LAD, probably doesn't quite jive, but it would be much more make sense that the guy's stent closed off. It was in the same distribution as his recent stent. And then lastly, if you see EKG ST elevation laterally, right, in the V5, V6, lead 1 on your 12 lead, then you're more worried about an occlusion of what vessel? Circumflex or a marginal vessel, right? So if they had an OM1 stent or something like that, then that would be that area, okay? And so, you know, we've talked about acute MIs. Now, what about ST depression? Let's say they have ST depression on their 12 lead EKG. What do you guys think about then?
yeah, but the cells haven't died yet.
Yeah, so we call it ischemia in contrast to injury. So they might have, you know, a 90% blockage there, or they could have 100% blockage there, but somehow blood is still squeaking by and they're not exactly dying yet. Traditionally, we're taught that that doesn't localize as well. I can see anterior ST depression, but that could still be like an RCA disease and stuff going on. It doesn't necessarily localize as well as ST elevation, okay? And so now that you got a kind of basic understanding of the anatomy, do you guys ever look at the stents that get put into the patient in terms of the numbers that are, you know, they say, we put in a this by this stent. How many millimeters by how many millimeters, that kind of thing?
No, I haven't.
Yeah, so a lot of times we'll say, you know, a 3.0 by 8 millimeter DES or BMS is usually the initial, or the abbreviations that you see, right? What are those abbreviations mean? So they'll write 3.0 by 8 DES or BMS, or they might use some brand names like Synergy or Rebel. No? Okay, so this is a drug-eluting stent, and this is a bare metal stent. This is one of the more common types of bare metal. This is one of the more common types of drug-eluting. And so, so that's important to know what these sort of initials mean. Why? What's the difference between this and this when it comes to what medicines they take? Okay. So after all stents, what do people need?
Anticoagulant.
So have you guys heard me talk about the ABCs? No? So anybody who has an MI or has a stent, we need to do the ABCs. A is aspirin and antiplatelets. B is beta blockers, and C is, sorry?
Calcium channel blocker?
What's the core measure? You're gonna we're all gonna get fired if we don't send the patient home on this.
ACE inhibitor?
Not for a MI.
Is it Coumadin? No.
Cholesterol medicines,
Okay.
statins, right? They all need to be on statins when they go home after an MI or a stent. And so if you have had a drug-eluting stent, then you need to be on at least 6, more likely 12 months of your antiplatelets, which is the abbreviation you might see as DAPT, dual antiplatelet therapy, which is aspirin, and what are the 2 antiplatelets that we use? So Coumadin is a anticoagulant, and we don't really use those in patients after this, after stents, not unless they have some other issue going on. So Plavix is the tried and true one, and what's the newer one that we use? So Brilinta. So Brilinta these are both antiplatelets. Think of them as super aspirins. So I need to have them on aspirin and super aspirin, and that's dual antiplatelet therapy. Other things that were mentioned just now, Coumadin, Eliquis. This is more of the anticoagulant family, and that is a much stronger blood thinner for other issues, namely DVTs, PE, AFib, those are, and some valves. Those are when they're on those kind of anticoagulants. Okay? So always remember your ABCs after someone gets a stent: aspirin and antiplatelets, beta blockers, and cholesterol inhibitors. So whenever you get a report from the cath lab and, oh, my patient had a stent, immediately I want you to think ABC. Just reflex, ABC. And then as they're talking to you, you want to know that they're on their ABCs. And as you're sending a patient home who's had an MI, you want to know that they're on their ABCs. So drug-eluting stent, perimetal stent, Synergy, Rebel. And so we're talking about the sizes. So normally, like, these are all in millimeters, right? And you guys know how much a millimeter is, right? I mean, it's tiny. Like, basically, like, my finger maybe 1 centimeter wide, so that's 10 millimeters. And so a normal vessel, like the LAD, that goes down here, if we're putting stents in them, I mean, very rarely are you putting a 4 millimeter stent in. Kind of the most we'll see is like a 3.5, often just a 3.0 is the stent that we're putting in there in terms of the size of stents, so millimeters, right? When we're talking about 4.0 millimeter stents, you're looking at the right coronary artery here. So you could put a 4.0 here, maybe a 3.5 here, maybe a 3.0, 3.5 here. So just to give you guys a gauge of actually literally how big we're talking pretty small. I mean, smaller than the lining of a pen is how big these stents are. And so when they're putting the stents in, they're basically taking a wire into the vessel and then taking another catheter that's carrying the stent. The stent is here, and there's a balloon inside of it, and then you pump the balloon up, you fill it up with air, and it basically expands this stent that was compressed and expands it, and it fills this area here to try to keep the vessel open. Okay? And so, so let's say, for the purposes of just a discussion, somebody has a blockage in their LAD, right? We can go in with a stent effect like that. Same thing with the circumflex. Same thing with the RCA. So this is one way to fix blood vessels, which is with stents. What's other ways that we fix blood vessels? Or fix resupply blood flow to vessels because of blockages? Cabbage. Bypass surgery. So that was actually around even before we did stents, right? The first balloon to open up a blood vessel was in 1984. And the first stent was around the early 90s, around 92, 93. And so before then, we were doing bypass surgery. So how does bypass surgery work? How do we resupply blood flow that way?
Use a graft from a vein in the legs, and then you, I guess, reattach it to the heart and just do a bypass?
Yeah.
Bypass
So
whatever blockage you have?
So describe to me, where would that be? Where would so I'm taking I clip out a segment of vein, my saphenous vein from here, and what do I do with that? Like, where would I put it?
I'm assuming you would put it before the blockage and then route it after wherever.
Right, and I want to get to this because we talk about bypass, but I don't know if people actually kind of get an idea of where the bypasses are going and coming from, right? And so let's say, let's try and put a message here. Okay, So I've got my LAD, and I've got a 90% LAD. And let's say the year is 1970, and we didn't know how to do stents, and so we needed to do bypass of this vessel, right? So, and I've got this vein graft here. Essentially, we take the vein graft, and we sew it in here to go around it, right, to bypass. But where the origin of bypass is actually the aorta. So here's our coronary artery here. This is our aorta. And just like how the left main coronary artery comes off of here, we actually put a graft here so that blood flow comes, a red blood flow comes out here, goes up here, and then goes down this way to get blood flow there. Does that make sense? So it's really an aortocoronary bypass is probably the more descriptive and accurate way of saying it. It's not just coronary bypass. We're actually going from the aorta to the coronary artery. And so if someone's got 3 or 4 vessel bypass, they literally could have an opening, you know, their original 2 openings here, and now they've got another opening here, another opening here to go down this way, another opening here to go down this way. Like literally they have multiple different things arising off of their aorta to supply blood flow. Okay, so that's what I wanted you guys to know, is that when you do coronary bypass surgery, we're actually going aorta coronary bypass. So that begs the question, this whole area here isn't really getting blood flow the way it could go if the blood flow were to go this way, right? So I'm rerouting the blood flow this way, so all this area is getting good blood flow, but this area where the blockage was and before where the blockage was is no longer getting good blood flow. So in many ways, stenting could supply better blood flow to more of an area. The problem is stents can go bad over a while, and in certain patients, especially diabetic patients, bypass surgery has been shown to last longer for a lot of those folks. Some of those trials are a little iffy because those look at different types of stents and the types of stents, especially with the drug-coated stents and things like that. Those don't close off as fast as the older stents did, and so because of that, it's kind of a constant changing race between bypass surgery and stenting. But because stenting is less invasive and because we're making better stents, we can probably do more vessels than we used to be able to do, obviously, than with bypass. So, and yet we still do plenty of bypass, right? What do you think is the reason to do bypass instead of stenting now?
Too extensive.
Yeah, there's too much. We can't put in 5 stents sometimes, you know, I mean, or 5 different vessels. And so that's when you would have, when you have many vessels involved, that's when you end up doing more for the patient by doing more vessels that way. And so in regards to what you're saying, you rarely hear of a 1 vessel bypass. It's more often 2, 3, 4 vessel bypass. If they just have 1 vessel disease, almost always we can get away with a stent, except here. What vessel have I talked about today that you've not really heard stented at all? Okay, so this is our what? What vessel is this? This is the vessel that comes over here. It's got the little vessel perforator. So what vessel is this? That's what? Coronary. Well, the left coronary is right here that comes off the ostium of the aorta. So we'll call this the left main coronary artery. And then it branches into 2 vessels. One goes down the front and towards the down part of the heart, and that's called the LAD, right? And then this one is the circumflex, right? And then this one is the RCA, right? Okay. We've heard of stent here. We've heard of stent here. We've heard of stent here. You've even heard of stent in the diagonal sometimes, if they're a big diagonal, or a stent in the marginal. We've heard of stent in the PDA. What vessel is labeled here that we've not really heard much of stent?
Posterior. Is it posterior stent?
Sometimes we can stent the PDA still if there's like if it's big enough. It's going to be a small stent, like a 2-0 bed. Yeah, like when's the last time you had a person with a left main stent? We don't really hear, certainly not naive left main. You might have someone get a left main stent if they had bypass surgery already. let's say they had bypass surgery to the LAD because they had a major blockage here, but then their bypass to this vessel went down, then they might stent the left main to help restore blood flow. So the reason being is that it's a little dangerous to stent the left main by itself because you're going in there and you have to inflate this balloon, and when you're inflating this balloon, what are you doing? You're basically starving most of the heart for blood flow the time you're inflating that balloon. So we would call that unprotected. Whereas if someone's got already a bypass graft to their LAD, they're already getting some blood flow to their LAD, I'm not putting everything in jeopardy by stenting this, okay? And so unprotected left mains, in Europe they did it more, in the US they don't really do it that much. Now we're starting to do it a little bit more because we have other ways of helping support the heart while we're doing this. And one of those ways is with the left ventricular assist device, like an Impella. So if you have a pump inside the heart and actually helping the heart work while we are like pulling the cord and everything, then that at least gives us some time to help do that. So you might start to see more left mains being stented now, but certainly 10 years ago we weren't. Okay? So that's the reason why we often do bypass. If someone has severe left main disease and they're a good candidate for bypass and they have lots of other vessels being blocked, and literally you could have nothing else blocked or anything else blocked here, but if you've got a 90% blockage here, these are all basically blocked. We need to resupply blood flow to these areas. Make sense? Okay. So he talked about vein grafts from the legs. Where's the other place that bypass grafts come from? Yeah, so that's what we call the lima, the left internal mammary artery. And so where is that? Yeah, it's inside your chest. Yeah. And it's inside your chest wall. And so what happens is I have my subclavian artery. I supply the blood flow to my left arm. And essentially right early on, there's a branch that comes off and it supplies blood flow down my chest. And I have one on my right, so I have a right internal mammary and I have a left internal mammary. And that basically supplies blood flow to the rib cage. As it turns out, it's kind of an unnecessary vessel in the sense of I got other ways to supply blood flow to the rib cage. And so they said, well, let's just take this vessel and reroute it into the LAD, and that's how we supply blood flow to that way. And so give me an example of some differences between what a lima might do versus what a vein graft might do to the heart. Like, in other words,
lima would supply more blood flow to the arteries that's going to be larger.
So it's actually smaller than a vein. A vein graft is going to be huge. A vein graft out of my leg might be like 7 millimeters, whereas a lima might just be like 2, 3, maybe 3, like 2 to 3, depending upon the person and stuff. So just like you've seen people with varicose veins, like, I mean, their veins can be huge. These veins, because they're supplying blood flow from the feet going up, they're big and they have these big valves. So veins are much bigger. So that's one difference. Veins are bigger than arteries. What are some other differences between veins and arteries in general? And then think about how they might apply to this circumstance.
Veins are less muscular?
Much. So if you look at the cross-section of a vein, it's like paper thin. Whereas an artery has much more muscle in it. That artery can constrict, relax, and whatnot. And so an artery is more muscular, so potentially maybe more durable in that regard. Think about their function, right? What kind of pressures do arteries see? What kind of pressures do veins see? Yeah, I mean, you're looking at blood pressures of 120 over 80. That's how they live, right? And then these might have blood pressures like 20, 10, 5, in terms of the pressure. There's no heart pumping blood flow in my feet, sending pressures back up, right? So all that is just central venous pressure. So CVPs that are, 5, 8, 10. And so that's why they don't need to be so muscular. They don't deal with that much pressure. That being the case, they're going to break down much more quickly. Average vein graft, after we put it in bypass surgery, the lifespan of an average vein graft may be 7, 8 years on average, whereas a lima, 20 plus years. Okay? And so this is kind of the most important of the vessels, the AKA widowmaker vessel. If we're gonna have to revascularize that, let's put the best vessel in there. So that's why we often see lima to LAD. Okay? and then the vein graft the other one. Yes.
So also though with a patient, say they have a really extensive PVD or some other issue, so would you maybe opt to use the memory instead of the saphenous?
Well, so number one is because this is better, like I said, you're going to use it, that's your first choice. So we're almost always going to use a Loomis LAD. The question is, for choice number 2, 3, and 4, we're basically left with vein grafts. And so if we're doing one vessel bypass, for sure, Loomis LAD. You could make the argument for it, but then it just becomes technically a lot more difficult. Well, we got 2. Why not use the REMA too? And so sometimes we use the REMA if they're trying to resupply blood flow to the right side of the heart. It's just technically difficult, and so we never really see that. We almost always just see the Loomis LAD and then the rest vein grafts. And then just the nuance of what you're saying, you said peripheral vascular disease, right? So when we say typically peripheral vascular disease, we're often most talking about peripheral arterial disease, and that's different than the veins that are coming up. Now, you can have horrendous veins that make it not able to be used for bypass surgery. So those folks might have, like, chronic DVTs. So again, we have to think about the venous side of things. So chronic DVTs, chronic lymphedema. Someone who's had stents to their legs or arterial femoral bypass, they might still have perfectly fine veins for us to use for this. But let's say that someone's had a bunch of DVTs, or they're just, frankly, super short. You can have someone with super short legs, and there's just not enough veins to pull out for this. Where else have you heard of veins sometimes being used? Or conduits is the better term to be used. Sometimes you can take a radial artery out of someone's hand and do that. That person actually has to have very good blood flow to the rest of their hand from the other, redundant route. But sometimes we'll take a radial artery out of there to do that if we can't get enough blood flow. And so that's what we call a harvesting. They harvest the veins from the legs, and they harvest it from other sites too. Any other questions about anatomy or revascularization?
This might be a stupid question, but is it possible to take it from someone else, like a vein and artery from someone else?
At this point, we haven't seen that. Is it possible? It certainly could be possible, just in the way that we do other transplants and things. But then you run into the big problem in general with transplant, which is what? What is the main problem that people have with transplant?
Rejection.
Rejection, right. So somebody thinks something from one person to another person, we have to worry about that. So that person would have to be on rejection medicine. It would be like a little bit more of a nightmare. And so typically we'd rather roll our dice with vein grafts that have 8-year lifespans or whatnot. Something I want to bring up that you kind of talked about a little bit. The vein graft is so big, and because they're so big, when they become problems in the future, clots can form in them. And then when they're so big and clots form, then it's tough to get them out. You might hear of a procedure where they try to get the clots out. Do you guys know what that's called? So that would be a thrombectomy, and they'll use something called like an angiojet or some device that basically literally sucks the clot out of the vessel. And that is more of a clot. That's different, and I'm being a little bit picky here. A clot is different than a plaque, right? And so a plaque is slow build up here, cholesterol, and then a fibrin cap, so it's a little hard thing here. And this can slowly grow over time. And then when I say grow, it's probably because something breaks, and then the vessel tries to remodel itself and patch it up. It's like this, crack down the side of my wall that I keep on trying to like plaster and patch, but then I grew up in New Orleans where the ground is real like moist and foundations move and stuff. And so you can literally stand on the side of a wall and you can see where someone's just sort of constantly patched over it, and it actually protrudes out of the wall. Imagine that sort of situation here where over time. In contrast, if I had a blockage here like this, but it was sort of ulcerated, person smoked or had bad genes or bad blood pressure, and then this cracked in a bad way, suddenly the body is sending all sorts of messages to try to fix this. And in a way, imagine like this crack in the wall, and this person just going nuts, just throwing everything you can at the wall, paper mache, plaster, all kinds of stuff. And this essentially just suddenly blocks off like this. That's what an ST elevation MI looks like. So it's a sudden break in the vessel and this is predominantly clot. So the distinction between plaque and clot. Okay? And so if you're in the middle of nowhere and there's no nearby cath lab and I have a STEMI, we give them what? Well, yes. I mean, you're giving them morphine, oxygen, nitro, aspirin. But what are you trying to do if you want to get rid of this clot?
Oh, ultrasound, or
Yeah,
if there's not.
yeah, TPA, right? You're giving them TPA. That is a thrombolytic. It's basically busting up a clot. It's not getting rid of a plaque. So that's the thinking is that acute ST elevation MIs, full 100% occlusion of vessels, that sudden is due to a clot like this. In contrast, the person who's had worsening angina over 6 months, where he used to be able to, I mean, this is a real patient of mine, he used to be able to bail, unload 50 bales of hay from his truck, and then, over the next couple months it's 40, and now it's 20, and now it's 10. This is a person who's had slow, gradual progression of coronary disease. All right? What time is it?
It is 12:27.
All right. I think we probably should stop there. Someone walked in this room, they think like, someone just threw a bunch of stuff on the wall there. Any questions here before we gotta wrap things up? So this is kind of like the way I'm hoping the talks go, in the sense of a lot of sort of laying the foundation in these first talks, and then subsequent ones, depending upon a topic, we'll try to show some more images of actual patients and caths and what we do during the cath. So, for heart failure, I want to show a bunch of echoes. For AFib, we can show tracings and what we do with TEE and cardioversion and stuff like that. And then for cath, and then for other things like stress tests, we could actually look at images of stress tests and CAT scans and stuff like that. Okay.
Okay.
All right. Thank you, guys.
Thank you, guys. Appreciate it.
I have a question.
Yeah.
Where can we access your other